So there is a lot of interest in what's called patient-reported outcomes, or questionnaires that patients complete in many fields of medicine. But the reality is, rheumatologists have been collecting questionnaires from their patients since about 1980, since the hack was developed by Jim Fries at Stanford. And he was one of the first ones to recognize that, the best way to understand how active disease was in somebody was to ask them what they could do and what they couldn't do. And then he worked systematically over a number of years to try and refine that questionnaire. By the time the 1990s came along, it was so clear to everyone that this self-reported information on disability was in fact the best predictor of where somebody was going to be in 5 years or 10 years. It wasn't what the doctor thought. It wasn't what the x-rays showed. It wasn't even what blood work was telling us. It was the patient's reports of what they could do and they couldn't do, how they felt, and how they were able to function. So I feel very much like the whole field of patient-reported outcomes is really strongly rooted in rheumatology and in arthritis care. What's been really exciting for me is to watch the evolution of this over the last 20 years. As I say, by the end of the 1990s, it had become very clear that you needed to collect questionnaires from every patient you saw pretty much at every visit. Now, in Canada and elsewhere, often the scores on those questionnaires are tied to treatment. So if rheumatologists want to be able to prescribe biologics, for instance, they have to be able to give a certain score that a patient achieved to justify that treatment with biologics. But what started to happen in the early 2000s is that there was more and more emphasis put on looking at beyond pain and disability. That's where most of the focus had been up to that time. And people started to look at, was there value in asking about other symptoms such as sleep or fatigue or anxiety and depression? Because it was becoming clearer that for some people, as their disease worsened, the first thing that they would notice was a change in how they felt emotionally, or a change in their sleep, or a change in what they not only could do, but what they wanted to do. That's a concept that we call participation. Physical function is, can you do the things that you need to do each day, throughout the day? But participation is, do you have enough energy left over to do the things that you want to do? Like Friday night, do you have enough energy left to be able to have people over for dinner? Or do you have enough energy left in the evening to play with your kids or your grandchildren? Or do some gardening or any of those kinds of things? And so questionnaires were explored in patients with rheumatic diseases such as rheumatoid arthritis to look at these various symptoms.